Breast cancer screening. In order to understand screening of breast cancer, we have to learn about risk stratification of population. Those at high risk are going to benefit more by intensive, frequent screening. On basis of individuals' lifetime risk of breast cancer, 3 categories are present: those having more than 20% risk are high-risk individuals, less than 15% lifetime risk are labeled low-risk individual, and in between intermediate or moderate risk. But how exactly do we know the risk in percentage? This is by various studies in which people with various conditions are followed for observing chances of breast cancer and through various risk assessment tools available online. High-risk category comprises of people who have previous history of breast cancer as etiological factor would have affected whole breast on both sides. People carrying genetic mutations known to cause high risk of breast cancer like BRCA1, BRCA2, PTEN, P53. If any first-degree relatives have high-risk mutations that includes parents and siblings. If any radiotherapy to chest is received at a young age like mantle radiation earlier given for lymphoma. Now we know the high-risk people, so how to screen them? Annual mammography with supplemental breast MRI, but both should not be done together, rather at 6 months gap, so that person is screened at every 6 months. This is to avoid interval cancer, meaning cancer developing in time period between screening. When MRI is not possible, HRUSG breast can be done. In addition, women must keep visiting appropriate physician for clinical breast examination. Now we know whom to screen, how to screen, when to screen, now at what age to screen. Annual clinical breast examination should start at 25 years of age. Mammography and MRI should be started no later than age 40, as purpose of screening is to diagnose tumor at early non-palpable stage. But both mammography and MRI must not start before age 25, as chances of malignancy before 25 is rare and false positive would be high, with decreased sensitivity of mammogram due to increased breast density. In women with history of chest radiotherapy, screening should start after 10 years of radiation, as there is latency period before cancer may develop, but screening should start no later than 40, not before 25. In women with first-degree relative with breast cancer, screening should start 10 years earlier than youngest case diagnosed, and again dictum, but no later than 40, not before 25. There are no separate guidelines for screening for moderate risk individuals. These are women with risk factors associated with lesser, 15 to 20% risk, like hormonal risk factors, and low and moderate group, annual or biennial, once in 2 years. Mammogram is recommended, starting with 50 years up to 75 years, between 40 to 49 years. Screening is optional with risk-benefit discussed with patient. After 75 years, screening can be done based on expected life expectancy. If it is at least more than 10 years, then screening can be done.